and welcome to another episode of A Divine Twist. I'm your host, Elizabeth, and today I have been waiting for this day for a really long time. Instead of having a patient and a person who's navigating dystonia, I have my favorite doctor here today with us, Dr. Stephanie Standal. Welcome,
Thank you
Stephanie.
so much for having me. Happy to be here.
Oh my gosh. Okay, so again, I've been waiting to do this for a really long time, and the people will understand why you are my favorites. And I do like to just share a little context with people how I meet people. And what's interesting is I literally went back to my notes, Stephanie, to see I
Yeah.
first met you on August 19th, 2019.
Wow. Okay.
So in August, it will be 6 years, and you probably remember
Oh,
when you
I remember that first day meeting you. Yeah.
tell the people what you remember about me in my case because it was dire, wasn't it?
Yeah. So you don't mind me?
No,
I mean,
I this is for people to learn and to see
yeah.
what's possible, I believe.
No, I mean, at that point, I started working at my job um in 2017. So at that point I had only been practicing for a couple of years, but I remember thinking I was like, wow, this is one of the this is probably the most severe case I've seen. Your head was very stuck. You know, you were very, very, we ended up getting some CT images of your spine, and your C1 and C2 were very rotated. I don't even know how many degrees, but they were not in alignment. And yeah, it was significant.
Yes, and I know the people that are watching this, hopefully maybe have experienced this where you just feel so hopeless and so desperate. And then some angel comes in on your path and you were the angel. And so I have notes. I take notes on things.
Yeah.
I was reflecting back on the notes from our first visit. And this might have been after, no, so we met first for the consult and then I had injections later. And I literally wrote, I'm giddy with joy because my head is so straight or something like that. And so I wanted to bring you on because this is your practice. This is what you work with day in and day out. And so I wanted to give that vantage point, that perspective, and just ask some, I don't know, clinical questions, some etiology questions for the medical people, and just share. So what is your educational background? Like, how did you come to be able to do this work, working with people that have dystonia?
Yeah, it was it was an interesting path. First, when you go into medical school, you have the world at your fingertips. You kind of most people start medical school just thinking, I want to be a doctor and I just want to help treat people, make them feel better, and that's certainly what I went into medicine thinking I was going to do. But you just don't know exactly what you're going to end up doing. And so when you are in medical school, you end up doing a lot of different rotations. They have you kind of test the water, you could say. And so they'll have you do a couple months of internal medicine, they'll have you do OBGYN and surgery, and then sometimes you'll get to specialize a little bit further. Sometimes, usually about halfway through your rotations when you're in medical school, you start to get an idea of what you're leaning toward. I was one of those people who I really liked everything, but so I was kind of just in the process of crossing out. Okay, I don't think I'll be a surgeon. I'm just not into that. I just didn't see myself in an OR suite. I wanted to have the face-to-face interaction with the patients. I knew that. I knew that about myself. And so yeah, I was just kind of going through and probably thinking I wanted to do something with older patients. I've always preferred, you know, older, not even just adults, but older. I kind of thought even maybe gerontology.
Yeah.
Um, but then I discovered just by chance, I had a really good friend in medical school um, who knew me well, and she had tried this specialty called physical medicine and rehab. And a lot of people don't even know what that was. Even people in medicine don't know about the field of physical medicine and rehab or physiatry. And so um, this was actually an elective that I took. They don't make you rotate in physical medicine and rehab in medical school. And so I just thought, well, my friend knows me well. I'll rotate in this. And I was sold like first day. I was like, wait. And so just to tell you a little bit about the field, so we don't in the field of physiatry, we don't really our main, if you could use just pick one word to summarize physiatry, it's function. And so that's our number one goal is to optimize people's function. And so we're not necessarily looking at labs all the time. We're not diagnosing things per se all the time. But we are looking at what people are coming to us with and saying, okay, I see you have this, that, and this functional deficits. How can we make this better? How can we make your quality of life better? And to me, that just fit my personality to a T. It's kind of a big picture type of field. And
Mhm.
so I was like, all right, I'm sold. And so I did another rotation that second month. I was able to sign up for another rotation in physical medicine and rehab. So I did a second month of it. And because this one was more generalized. So I did another month. And this I happened to just be matched with a provider who did Botox like all day. That's all he did. And so I was like, this is really cool. This is really fun. And the patients were so happy when they'd come back to see him. And I realized I was like, okay, I want to do this specifically. I
Mhm.
want to do this. And this provider, he treated more spasticity related problems with Botox. There's a number of different conditions that you can treat with botulinum neurotoxin, and spasticity was kind of his niche. So I did my medical training in Milwaukee. And then I went and did a residency training program at the University of Minnesota. And the chair of our department at the time, his name was Dennis Dykstra. I don't know, did you ever meet him?
He literally was like, I don't know if it was his last week before he retired. So
Okay.
I got to meet him.
Yeah.
And yeah, like
Okay.
he's the guru. Like if you, right?
Yeah. So he had been practicing in the world of physical medicine and rehab for 30 years, and he was the chair of our department. And he had this special little niche where he was treating dystonias with botulinum neurotoxin, and he was kind of a pioneer in the field. And I knew all about him. For somebody who's a medical trainee and they are interested in neurotoxin injections, he's kind of a celebrity. And so when I met him, he's a very funny guy, and he asked me what I wanted to do when I grew up, and I said I want to do what you do. Um, and who knew that a couple years later he would offer me his practice when he retired. So it was amazing. So I didn't necessarily go in thinking I would specifically treat dystonia, but I quickly became really interested in the condition and realizing how much skill that would actually take to treat. Because that's the main thing he did. He treated cervical dystonia. He was also the chair of our department, so he had other duties. And so, but I took on his practice, and he retired officially. I actually trained under him for uh, about 2.5 years, or about 2 years before he formally retired. So I got a lot of one-on-one mentoring from him. And yeah. And then, he's now been retired since 2020, and the clinic has really grown. I fill 5 days a week with patients, and specifically my interests are treating dystonias, um, and I have a specific interest in treating dystonias from the neck up. So I treat a lot of cervical dystonia, oromandibular dystonia, facial dystonia, certain like hemifacial spasm and other facial dystonias, but I will also treat other limb dystonias and trunk dystonias as well. And the reason I really like to focus on that area is because it's a high stake area to inject neurotoxin into. Because you'll meet a lot of people that will treat limbs, but limbs are not that risky, I guess you could say, to inject. So it's nice to be. I do this all day, every day, And I've found that not a lot of people treat this area all day, every day, the way I do. So
And I mean, I'm a nurse and
yeah,
I only want to go to the person who is the clinical expert, skill wise, and also has wicked awesome bedside manner, which you fit the bill on both. I have to ask, how scary was it the first time you actually did the injections? And did you always do it with electromyography?
yeah. So the good thing when you're in residency training, you do a lot of Botox, a lot of different, it I'll call it Botox, but it's Botox is kind of like how we call tissue Kleenex. Kleenex is a brand of tissue, but they're all tissue. But so Botox is the most commonly known neurotoxin. But we tend to just call it Botox, but it's the different neurotoxin. So yeah, we spend a lot of time in our training with learning how to do neurotoxin injections. And so you watch a lot and then you do a lot. And yeah, I mean, I think probably it was more scary for me when Dr. Dexter left because it was just me and the patient.
Like,
And
here you
for some,
go.
it wasn't that scary when he was there. But
Yeah.
at some point he left and he said, Stephanie, I feel like you've got your wings. And
Aw.
that was, and it's been really good. We've been
Yeah,
able to
I mean,
carry on that.
I have to say well, I don't get nervous because you're the one doing it. However, of course, that autonomic nervous system, every time you give me the
Yep.
ice pack, which I'm so grateful for, my palms get sweaty, my feet sweat. I'm like, oh,
Yeah.
okay, here we go again.
Yeah.
Okay, so I love the story of how, th this fluke, my friend, like said, you might like this PM&R thing. And as a holistic integrative nurse, this is why physical medicine and rehab rings all my bells because to me, it's very holistic, big picture in nature. And at the end of the day, it's like if you have a dysfunction, the whole goal is to be able to do what you need to do to thrive, right? And so I love that about this specialty, and it makes a lot of sense to me that this specialty would treat something like the dystonia. Specifically, I love how you said I like to treat above the clavicle. Like this is a very risky. So tell us why it's so risky.
Yeah, and I mean, I don't say that to scare people because I don't think if you're going to go see a specialist and they're trained and can inject for and treat cervical dystonia, I don't think that the procedure itself is that risky, but I think it's not something that you want to dabble in as a provider. And so I have, you just, and the reason why is because, let's say that you are injecting somebody with, I guess we'll go back to the way botulinum toxin works. So that's kind of what I'm doing most of my day is I'm injecting neurotoxin into people's dystonic muscles. And the goal is that we're trying to relax the muscles. The brain is telling those muscles to overfire. The brain is saying you need to work way harder than you're meant to. And we don't really, aside from doing a brain surgery where you're doing DBS, which if you wanted to talk about at some point we could, but we can't really get into the brain and tell the brain to stop sending those signals at this point in medicine. Um, in a non-invasive way. And so what we do is we will take botulinum neurotoxin, inject it into the overfiring muscle, and we're essentially telling that muscle, you're too weak. We're temporarily weakening the muscle, not to the point where you can't use the muscle, but to the point where it stops behaving that way, if that makes sense. So,
Yeah.
so
So it's the chemical messenger of acetylcholine, right? That's actually
yeah.
what it's
Yep, it's inhibiting the release of acetylcholine, which then gets released into the neuromuscular junction and allows the nerve and the muscle to communicate with each other. And so it kind of dampens that
Mhm.
response. And so then it can't do that so much. And so the goal is not to paralyze the muscle, it's not to weaken the muscle to the point of not being able to function, but we are trying to get that muscle to stop overfiring so that it can act more normally. And
Yeah.
so when you're injecting into the head and neck, if you can, I mean, if you think about it, I mean, you're using your neck muscles all day to hold your head up. And we never think about our neck muscles because we just automatically hold our head up.
Yeah.
But if we weaken them to a point where it's hard to do that, it's really uncomfortable because all of a sudden you will feel kind of like a bobblehead, and we just really don't want that to happen. And so for that reason, I think that it's a little risky. It's a little riskier than doing like a limb, for example, that you could get by. The good thing is, though, is that that's temporary. Usually, if somebody has that side effect, it won't last very long, usually
Mhm.
a couple days to maybe a couple weeks.
Yeah.
But it's something that it's another reason why my approach is always less is more. So we always start really conservatively and work our way up. Whereas I sometimes see that people will go to a provider and they'll do this injection, and then sometimes they'll get too much. And
Yes.
so,
And as a nurse, we know this. Like, once you give too much, I mean, it depends on what kind of drug it is, but you cannot take back what you gave.
yeah, you
So
you can't. You just have to wait it out.
yeah.
Yeah.
So, you use electromyography,
Yeah.
right? And
Yep.
so so for people maybe who've never heard of it, can you tell us a little bit about how that works and has it been proven to be more effective? Or to me, it seems like duh, like
Yeah.
you can palpate a muscle all day long, but sometimes that's not the full story.
Yeah. Yeah,
So,
absolutely. So the EMG basically is allows our procedure to be guided. So what it is, it's a hollow needle, and at the end of the needle is a syringe that where there's the medication in there. But there's also, I always describe it as kind of like a little microphone at the tip of the needle that can actually listen to the muscle activity. So typically in a muscle that's not if you are resting your muscle and you are not moving it, there should not be any muscle activity. It should not be firing. However, in a muscle that's dystonic, it's going to be firing involuntarily, and that's
it
dystonia.
sounds like a Harley Davidson, if you
Ye-
ask
It
me.
does. Yeah, it's really loud. Yeah, and so it's kind of like, I don't know. So for me, one time when I was training under Dr. Dykstra, I asked him the question. I said, why don't you use more ultrasound?" And he is like, "That's a really good question." Because you would think, well, don't you ultrasound, you can actually really see the muscle. But I care more about what the muscle's doing than that I'm in one particular muscle, you know?
Yeah.
So I will take my EMG needle and I'll put it into the surface of one of the muscles where I'll use my clinical judgment to kind of guess which muscles are active. But then I'll take the needle and I'll put it into that dystonic muscle, and maybe I don't hear a whole lot. And so maybe I'm going to move my needle to a different spot within the muscle, because what I'm really looking for is the muscle activity to tell me, yes, this muscle is dystonic. It's moving too much. It's contracting and it shouldn't be.
Mhm.
And sometimes you'll get into the muscle and it won't be very noisy, but you'll go a few layers deeper and boom, there it is. So I think it really helps guide the accuracy of the injections. And so I wouldn't want to not use it.
I'm, as a patient, I'm 100% with you. It's like, why
Yeah.
would you not use this? And of course, that's another skill, right? You have to be trained, you have to really know how to use it. And so you would want the provider to know what they're doing, which leads me to this question. So, physical medicine and rehab, I mean, you are a medical doctor, right? And a neurologist is a doctor who specializes in stuff with the brain, which seems like a good fit for treating somebody with cervical dystonia. Who is the best type of provider to both? I know that physical medicine and rehab is not into diagnosing, but for someone to assess, diagnose, and treat cervical dystonia, who's the best? Or like what's the most appropriate category
Yeah.
for
That's a good question. I don't think there's really a black and white answer to that. Generally, I'd say in most cases um it would be a neurologist that would maybe be like a movement disorder specialist.
okay.
But really, I think the main the right answer to that question at all is the person who treats this condition, really. So they might be a physiatrist, but they might be a neurologist. And it kind of depends on where you're at. Um, where I am at, we both specialties treat this.
Okay.
Um, and so yeah, I think the best person to treat it is the person that treats it regularly. That's probably the best.
Yeah, I love that answer. And from the patient population, I mean, I've heard different things for ti onset of symptoms to actual diagnosis can literally be 8 to 10 years. So as a provider yourself, who you don't, there's not enough days in the week for you to see the amount of people who are navigating this, it seems like, right? How,
Yeah.
what would you say to someone in the medical field who has never heard of cervical dystonia? Like, it exists. It seems pretty common, which is why I think it takes so long. Like what would you say to another provider or wish for them to know or, you know, to make
Yeah.
your and our lives easier?
Yeah, I know, right? Well, I will say I used to see that more years ago. I don't see it as much now. It seems like people are being diagnosed quicker and quicker because there's just becoming more awareness of what cervical dystonia is.
Yeah.
Um, but I would say, because I would say to a provider, if there is somebody who is having symptoms that just kind of seem, you're not sure what is actually going on, but it seems like there's some kind of pain in the neck region or focally in a region that's muscle, and you think it's muscular, and you can't really identify a particular nerve. Um, you might want to consider is there a dystonic component? Is this dystonia? Because typically it's the muscles that will be the ones that are moving abnormally. Um, there are a lot of, so cervical dystonia is the most common form of focal dystonia. And so that's why I see that the most and I treat that the most. And so we use that as a more common example. But we think that the more, because the way you came to me, it was severe. And but a lot of the more there's actually been some recent papers that have been come out in recent years that have shown that actually there are a lot more people that have it that are the cases are more subtle, and so they're not severe, but actually when you take a look at them, they actually do meet the criteria for cervical dystonia, and that those cases tend to take a lot longer to treat. I would
Tell
suggest
us,
come to a
tell us
diagnosis.
what is the actual criteria for an official cervical dystonia diagnosis?
Yeah, that's a good question. So essentially, in order to be diagnosed with cervical dystonia, you have to have some form of involuntary movements of the head and neck muscles. And some the diagnosis can be it can vary. So sometimes they'll say like an insurance company will require that the abnormal contractions of the muscles will be prolonged, or meaning that the muscles get held in a certain way for a certain amount of time. But other times I'll see that, and I think what they're trying to get at is that they don't want people to just have a head tremor where it's just very quick back and forth. For some reason, insurance doesn't like to treat doesn't care about your your head tremor as much. But so they want to say often prolonged contractions. But yeah, it's basically abnormal movements of the neck muscles that lead to some involuntary posturing. But like I said, it can be quite severe. There's quite the
Right.
spectrum of the
Yeah.
symptoms. And so it can be rather mild where there's maybe just a slight tilt. And so I usually have people just close their eyes and sit and kind of let their head do what it wants to do. And oftentimes, because people will hold it and they can, there are tricks that people can do. They might sit with their head on the back of a
Mhm.
chair rest or a wall, or they'll hold their chin or something. So
Shift day antagonist, the sensory trick, right?
yes,
Well,
yes,
I'll never forget. I don't know. It was like a couple years in when this is what you said. I actually did a post about this. I was like, the words that my doctor said just changed everything. And you literally said, just let your head go where it wants to go. And I was like, the Alleluia choir like started singing. And I was like, because I think also involuntarily we're fighting the contractions and it freaking makes everything worse. So, okay,
yeah.
so it's literally just involuntary movement of the head and neck. And how is the diagnosis made?
So it's a clinical diagnosis. And so I told you that physiatrists don't typically diagnose conditions, but in this case, I would certainly be qualified to diagnose this. However, and so yeah, I would take a look at a patient, and if they would meet the criteria, if they have some type of abnormal posturing of the neck, to where the head is twisted or bent a certain way. So there's different types, and usually it's so there's different type. Another word for this is torticollis.
Mhm.
But there's antericollis where the head is pulled more forward. There's retrocollis where the head is pulled back.
Mhm.
There's laterocollis where we're kind of side bent, and then there's torticollis where there's a rotation component. More often though, it's a combination of the different movements. And so, but yeah, I mean, if your head is so typically what would bring usually somebody's not going to come to me with especially if it's subtle, they're not going to usually come to me if they're like, my head is like this, they would just do this,
Yeah.
but it's often accompanied by pain or
Yeah.
stiffness or discomfort
Yeah.
of some sort. So
So this seems like there's a lot of I don't know if confusion is the right word, like out on the internet streets, Google maybe, whatever.
yeah.
Um, there's no lab, there's no blood work, there's no urine test, there's no imaging that gives somebody the clinical diagnosis of cervical
That
dystonia.
is correct.
Yeah.
However, when somebody gets diagnosed clinically with dystonia, it's a good idea. I like to cross all my T's and dot all my I's. And I still like to have them worked up by a neurologist because there are a few conditions that are reversible that you could treat. For example, abnormal accumulation of copper. Or you could have it's uncommon, but it could be like a dopamine responsive type
Mhm.
of dystonia where you could take dopamine and your symptoms will go away. So I still like to have them just looked at
Mhm.
by neurology just to make sure there's nothing reversible that we were missing.
Mhm.
But yes, that it is still a clinical diagnosis. And I mean, even if you have something else that's causing it, you can still treat it.
Right.
It doesn't really change what I do,
Yeah.
but
Yeah.
um, yeah.
Okay. Thank you for that clarification. It's good to set the record straight. Okay, so we talked about what is cervical dystonia. This is my most curious question. What are the risk factors for cervical dystonia, if there are any?
Yeah, I would say probably the biggest risk factor we think is there could be a genetic cause in a lot of cases. A lot of cases not though. But I always when somebody comes to me and they have what looks to be cervical dystonia or any type of dystonia, I usually like to ask about family history. So did you have a grandma or an aunt or an uncle or somebody in your family that um, perhaps had some kind of maybe a head tremor or maybe they had this, is there anyone in your, and oftentimes we can point to, yeah, there was
Hmm.
so and so in my family and I never really thought of it, but yeah, their head was always in a weird position or something. So oftentimes genetic. Um, sometimes I'll see people who have had a big traumatic event, such as a car accident,
Mhm.
um, or a big fall, and
Mhm.
these abnormal posturing, this abnormal posturing can occur uh, slowly but surely over time. It could be years. It could be a few months. It could be years.
Mhm.
And so we think that there's some kind of shearing kind of micro trauma within the spine where the muscles are contracting in a way and it tries to be protective, but it ends up being kind of pathologic because the all of a sudden the head's cranked in a way that it shouldn't be. So often it can be traumatic related, but we don't, this is, also we don't always know. Sometimes it'll just come
Yeah.
out of nowhere and we just can't figure out. And there's probably a good explanation for it,
Mhm.
probably genetic related, that we just don't have all the answers to yet.
Yeah, I mean, especially because it's, at least from what I understand, that this is coming from the basal ganglia,
Yeah.
the miscommunication from that portion of the brain. So
Yeah.
perhaps some type of physical trauma, I don't know, jiggles
Yeah.
up the basal ganglia and it gets all wackadoodle.
Yeah.
Um, okay, so that is super helpful. So now, okay, so my other sort of question that's sort of related to that is, what in the world, how does this dystonia decide where it's going to land? Like, so I have the cervical dystonia, so head, neck, and shoulders. Why do some people get it in their limb, like in their leg, or like what is that
Yeah.
about?
We don't really know. We don't
Isn't
really
that
understand
weird?
that.
Like,
Yeah.
why I got it in my head and neck, but they got it in their trunk? Like,
Mm-hmm.
what?
Mm-hmm.
That part, so we don't really know. Like, what's okay.
Yeah, it kind of just depends on where in like what part of the basal ganglia is affected.
Okay,
Um,
so hold up. So is there a certain real estate in the basal ganglia for different parts of the body?
well, yes and no. I mean, really, the basal ganglia is kind of the part of the brain that helps coordinate movements.
Yeah.
And so, the neurologists will kind of look at you and decide, okay, based on your pattern, what's going on, we would maybe if, and this is when it gets to the point where you're doing, if you go into deep brain
Yeah.
stimulation, and that is not anything I do,
Yeah, yeah,
but
yeah.
some people ultimately opt for that. It tends to be the more severe cases,
Yeah.
but yeah, they'll do some mapping and they'll test various parts of the brain and the basal ganglia to see how they respond.
Okay.
So
I was like, that's, I just think that's real interesting. Like
I
where it
know,
should
right?
show up. And so, okay, so that's super helpful. Okay, now
Yeah.
there are a lot of questions about this, and that I have also wondered, what is this thing that I see on the interwebs called functional dystonia?
Yeah, yeah. It's, functional dystonia, typically when somebody comes with the diagnosis of functional dystonia. So I would never personally diagnose somebody with functional dystonia, but usually what they mean by that is that they haven't found anything organic to make sense of why these abnormal movements are occurring. And they don't seem to be typical. Um, the movements don't seem to be typical, and maybe even that it can be kind of distractible, or it just kind of tends to be atypical, not what somebody would expect. And so when so typically I tell people if they've been diagnosed with like a functional dystonia, so those people are they tend to be a lot more prone to having exacerbations, to having their symptoms worsen by high stress situations. And so those people need to probably have um, really good management of other situations in life
Yeah.
beyond just getting the neurotoxin injections. Oftentimes they could benefit from seeing a psychologist or something because, like I said, certain stressors can really make it way, way worse.
Mm.
And it's the brain is kind of not acting in a typical organic way. We think it's more like emotional type cause.
Okay. That makes sense. Now that kind of leads me to the next question. Now I have read that the non-motor symptoms, they call non-motor symptoms of depression and anxiety, are expected or part of this cervical dystonia. Is that like what, and if that's true, what what advice do you give to those your patients about how do you how do you deal with these non-physical parts of this whole kit and caboodle we got going on here?
Yeah, I mean, well, kind of like what you alluded to before is that, I mean, it's kind of a big picture. If you're not taking care of your mental health and you're in a super stressful, horrible and life circumstance environment, everything's going to be worse. You know, if you're not sleeping well, if you're not, you're not exercising, you're not practicing stress reduction, you're not managing your mental health. I mean, it'll make everything worse, really. And and that is the case for a lot of conditions just in the care world, and this is just no exception.
Yeah, stress exacerbates all known conditions.
Yeah, exactly.
Flares, exacerbations. Okay, yeah. But that's a whole nother I won't even make that comment because that could take us down a whole new track and we're gonna stay on the straight and narrow. Okay, so um well you kind of already alluded to this, but I'll ask anyway. Are there any things that a person with cervical dystonia should just flat out avoid? Like don't jump out of a helicopter in Vail, Colorado. I don't know. Like, is there anything that you would just be like a hard stop? I wouldn't recommend that.
You know, that's a good question. Um, I don't think that there's anything that puts somebody with cervical dystonia at higher risk. You know, for example, your spine, unless you're in a really, really bad position, I can't imagine that you would be at a higher risk of getting, for example, like a spinal cord injury or something.
Yeah. Yeah.
Um, that in and of itself doesn't really predispose you. However, we usually just advise people to probably the worst thing you could do is if you get diagnosed with cervical dystonia is to quit your job and stay home and decide that you're a sick patient. And
Hmm.
I mean, that'll probably make you worse.
Okay, I'm so glad. Okay, yeah, because
But I think you can do anything really.
I this is why I love you because you see people in our vitality, you see people in our wellness, no matter what the label is, right? And I this
Yeah.
is why I wanted to have you on here because they're it's how we respond to the
Yeah.
label. It's how we respond to what our physical body is trying to share with us. It's very wise, right? It's just, are we listening? Most
Yeah.
most of us aren't. I mean, I'm very biased, but I believe those of us who have been tapped on the shoulder with the dystonia thing, we are a rare breed of awesome. Like
Yeah.
we, and you have these patients, so you know what I'm talking about.
Yeah, absolutely. I would say, there's really minimal things that you could just say, no, I'm not going to do. You
And
know, I mean, certainly,
yeah,
I think it's using good judgment and avoiding, some people say that the winter months are just harder on them. Muscles don't really love super cold weather.
yeah, yeah.
So that could certainly make things worse. High stress can make things worse. If somebody goes through a death in the family, I mean, obviously they're probably going to be doing worse, with their dystonia.
Yeah,
Um, but yeah, I wouldn't say that there's anything specific that they need to avoid. I would not say that the answer is you should stop everything that you're doing. And,
yeah. I love
I would
that.
say staying moving is probably the best thing you can do.
Yeah, movement is medicine. Okay, so that brings me to so a little bit of a different vein here that we're gonna go in. Um, is okay, so there are people who either are like, I am not putting a neurotoxin anywhere near, much less in my body. Probably those people aren't coming to you, or maybe they are for a consult.
Yeah.
Like, is there what is your next best option for those people?
Yeah, no, and I see that a lot. And I feel like that was even kind of you because, right, because you're not, and I get it. I get it. I feel like the longer I've practiced medicine, the more um averse, the more I don't like medicine, really. I'm just less is more in every sense of the word and in so many ways. Um, and so I would say I think that's really valid. I think that I understand if somebody doesn't want to put a neurotoxin into their body, and a lot of people don't. Um, Probably what I would do is I would just go over kind of the options really. I mean, like you were doing a lot of homeopathic things, right? A lot of people will do the yoga and the PT and the stretching, and you can um, take muscle relaxers. Those are all good options. And I don't think that this is something that you go right into neurotoxin injections without trying some of those things.
Yeah,
Because it is, I mean, ultimately, if you end up undergoing Botox injections every 3 months, I mean, you're coming in to see a doctor 4 times a year.
yeah,
That's inconvenient.
yeah,
So I would say certainly exhaust other options first.
yeah,
Um, but unfortunately, yeah, there's not a whole lot besides what I just named, you know?
yeah. So that definitely can. I think that's part of what contributes to people's, I'll just use the word angst. It's like, really? These are my three options? Okay. And I like to say my physical anyway, my personal belief is I believe that if we believe something will support us, well, Henry Ford said, if you whether you think you can or you can't, you're right. If we have a belief in something that it will cause us harm, well, you're probably going to have that experience. If you believe something will help you, it probably will help you. To me, I see anything, whether it's a chemical, whether it's an injection or a tablet or a meditation, it's a bridge. It's just getting you from point A to point B. And sometimes you're so in the weeds you can't function. At one point in my life, I took antidepressant medications because I needed that bridge to get me to the next step, right? And so I would also add that before people poo-poo or just say hard no, like maybe could you be open to like the possibility or just trying it? Like there's only one way to find out if something works, you got to try it.
Yeah, and that's what I always tell people. I say, the good and bad thing about Botox and botulinum toxin in general is that it's not permanent.
Yeah.
So that's really good in the fact that you're not agreeing to do a surgery or something. It's
Yeah.
the outcome is not going to be permanent, but
Yeah.
you could try it knowing that it will wear off. And
Yeah.
you can kind of see if you really liked the effects or not.
Mm.
I always tell people, at least the way I do it, I start with a low dose.
Yeah.
And so because it's important to manage people's expectations and to
Yeah.
know, hey, I would much prefer giving you not enough than giving you too much the first time. And
Yeah.
so we're going to assume you're super sensitive to this. And so I'm going to probably give you absolutely not enough, but you're hopefully going to see some benefit.
Yeah.
And maybe you'll see that your head is pulling just a little bit less, or maybe you're having a little less pain. Maybe you sleep a little bit better because, those muscles have quieted down a little bit. Sometimes you don't know how much you're suffering with something until you're not anymore.
Thank you. That's what I do in my work. It's like
Yeah.
people are so used to feeling bad, they don't know what it could be like to feel good. And then when you feel good, they're like, "Ooh, where you been all my life?"
Hmm. Yeah, and I will never, ever, ever, ever beyond that first visit try and convince someone to do Botox
Yeah,
because I will let the Botox speak for itself.
yeah,
People are going to either know or that they need it or they don't.
yeah. No, I love that. Basically, giving a patient permission to have agency
Hmm.
over their own. One more quick question about the botulinum. I mean, is there like an average? So many people I see on the socials and the interweb saying, I'm about to go for my first injections. I don't know what to expect, blah, blah, blah. is there a sweet spot on average? Is it like it
Mhm.
takes 3 rounds to like get a good vibe, or what's your experience? Because
Yeah.
yeah,
Yeah, and I think the statistics in my clinic are pretty consistent with the average. And so typically I tell people to give it 3 rounds
yeah,
before we make a group, unless you absolutely hate it. But I say give it 3 rounds before we decide if it's worth doing, continuing or not.
yeah,
Because the first time you're just going to dip your foot in the water, you're just going to test it out and see, are they a hyper responder?
yeah,
Because some people will get side effects from just a baby dose. And I just like to assume everyone's going to be that way. And so again, I give a really tiny dose the first time. Unless the symptoms are really severe, then I might give a little bit more. But for the most part, we're going to give a pretty small amount that first time.
yeah,
Second time, if they do well, if they got any benefit whatsoever, but they had no side effects, we'll definitely go up. But
yeah,
like I said, usually by that third time, we kind of hit the nail on the head. And I think that's pretty typical
yeah.
anywhere you go. Um, the average for treating cervical dystonia, the average dose for Botox and Xeomin, because they're the units are
1 to 1.
interchangeable,
Yeah,
are 1 to 1. It would be about 250 units. That's
yeah.
pretty much the standard dose, the average dose. However, I normally would never start somebody over 100
Yeah.
that first round, unless their symptoms were pretty severe.
Okay, that's what I've heard. The 3 rounds. Okay, that's good to know. And then this is the number one question I see everywhere. Like, what are the rules after you get Botox for cervical dystonia? Can you swim? Can you get a hot massage? Can you palpate the muscle? What's the
Mhm.
deal with the Botox?
I know, and I wish I had a super good answer for you on that
Huh,
because we've actually met at the place that I work because like I said, the neurologists do neurotoxin, I do the physiatrists do neurotoxin, and none of us give any of the same guidelines to our patients. And I have heard some pretty crazy guidelines too that I would not agree with. But I generally say I think about it like this. And oh, and that's the other thing. The makers of the neurotoxin don't give really strong strict guidelines either on that. But so we kind of use more common sense
yeah,
approach. So the one thing that we for sure recommend is to not massage, especially deeply massage the areas that were injected for at least 4 hours. But to be extra conservative, we say give it a week to even 2 weeks before you get like a deep tissue massage in the area. And that is just because if you think about you've injected the medicine into the muscle, you don't want to move it around. And
yeah,
it's not even so much that you're going to have problems per se, even if you do that, but you want it to kind of stay where you put it.
sure.
And so to let it kind of absorb into there. I've heard some people say to not apply direct heat to the area for a good several hours. I've heard where I've heard cosmetic Botox providers will say not to lay down for 24 hours. I've heard it all. But typically we more just recommend not to have it massaged. I think my neurology colleagues will say not to work out for 24 hours. I don't know if I necessarily agree with that. But I guess it makes sense that if you sweat, maybe you could sweat some of it out, I guess, or
Yeah,
you could interfere at least with
yeah,
the
yeah. I
the
mean,
injections.
the deep tissue thing, right to the, that makes sense, but it's interesting
Yeah.
how everybody has a different vantage point. Okay, one
Yeah.
more question.
Hmm.
Okay, so this person asked, um, my cervical dystonia spread. If it goes from the right neck to the left neck and down left chest and left arm after 20 years, is it called segmental and will it continue to spread?
Yeah, that's a really good question. So okay, so there's focal dystonia, there's segmental dystonia, and then there's generalized dystonia. And so the most common form of focal dystonia is cervical dystonia. And so that is where the neck muscles will be involved. And so you don't, if it's the right side, left side, they're both, it's all cervical. That would still be a focal dystonia if it's involving just the neck.
Mhm.
Um, but yes, if an extremity starts to become involved, then it becomes more of a segmental dystonia. So it's a couple different groups that are of muscles that are involved. And I will say this condition tends to not be progressive. Um, and so it's not common for dystonia to spread. Um, I have seen some cases, but this is rare,
Mhm.
where another group of muscles will become involved, like a limb. Or
Mhm.
I've even seen cases where somebody may start out having a cervical dystonia, and then that cervical dystonia will go away, and then it'll become their jaw, their facial muscles will
Mhm.
become involved. And again, we don't fully understand why this happens, but it can happen.
Yeah.
But again, like I wouldn't the rule of thumb is that typically um this does not progress.
Okay. Okay. Thank you for answering that.
Yeah.
Okay, so that's a lot of questions, and we've already gone. I wanted this to be short and just relaxed, and you have delivered so much amazing, awesome information. So I'm just so grateful. What would you say, or what do you say to somebody who comes in and they're like, "Do I have what advice would you give either both the patient and or a loved one who is hearing this information?" Because, yeah, what would you say?
Hearing that they
Have cervical dystonia or that their loved one, yeah, because you have such,
yeah, I would say that this is not a death sentence. This should not, and this really, this is it's a frustrating condition, certainly. But there are really good treatments available. And yes, unfortunately, we don't know how to, at this point in time, we don't know how to cure dystonia. But we've come a long way in the world of neurotoxin injections. That's probably the gold standard treatment that is the gold standard treatment at this point. And that has been the case for a lot of years. But there are, there's a lot of hope. And my goal is with all of my patients is that we can get them to live as normal of a life as possible. Generally, I would expect you to see at least maybe 75% benefit.
mm,
Ideally, I like people to forget they even have this for a while when they have the neurotoxin injection on board. But yeah, I would say that there's a lot of hope, and I wouldn't expect this to get worse. I would expect you to be able to live a completely um, functional life, and this shouldn't limit you significantly in terms of function.
mm, so good. This is why our providers make a significant impact. I learned this from Lynn McTaggart. She wrote The Power of Eight and the Intention Experiment. And
Yeah.
she really drives home the point. The the belief that your provider, no matter what, a doctor, coach, mentor, that person's belief and the patient to be able to be well is so powerful and so crucial. It's planting seeds. It's like, okay, well, if they say this, then surely everything's going to be okay. So I truly appreciate that. And there was oh yeah, my final question is there something um that your patients, is there like a common theme, or is there something that your patients who do extremely well have in common? Your patients who do really, they're just, they're
Yeah.
thriving. Is there some kind of theme, or is there something that you notice or that you observe that you're like,
Yeah.
oh, okay.
I would say you are a picture of that. I think just having a positive mindset and saying, this is not going to define me. This is not going to slow me down. And just being like, no, I'm not going to give in to this. I would say people who choose not to let dystonia be something that stops them from doing the things they love to do. I think that that is probably the most important thing. Um, and probably the most common, the people that do well have in common.
The mindset.
Yeah, and it all comes down to mindset. Yeah.
Yeah. I'm not going to be able to remember her name. Anyway, she wrote a book called Radical Remission about
Yeah.
people who had a spontaneous remission of neoplasms, cancers. They had 9 things in common. 7 of the 9 had to do with beliefs and mindset. So I believe what you're saying, and it has helped me tremendously because there were many years where I had the left lateral tilt and then my neck was twisted to the right. I couldn't drive a car. I was depressed. I was anxious. And one day I was like, you know what? This is ridiculous. What? So then I started imagining, what am I going to do when I can drive a car? Where am I going? What am I wearing? What am I talking about? And so that is what got me out of the many dark years of the soul. And I just want to be like the Roger Bannister. He was the first guy to run a sub 4 minute mile for the dystonia community that this is an opportunity and we get to play with it or dance with it or be pissed off at it. Like whatever, it's totally our agency we get to do. And so thank you for being on my path.
So happy to be.
Yeah, and I thank you so much for your wisdom and anything else before we sign off with a
Yeah, no, I would just say, I mean, you've blessed me in so many ways too. It's just been so wonderful knowing you and just I don't know, I gained so much from our interactions as well. So yeah, I would just say you would be the type of person I would want to follow for sure and listen to and just yeah, I think it's just wonderful what you're
Thank
doing.
you. Thank you so much. Now, I will just do a plug. So actually today we're filming this on Thursday, February 27th. Tomorrow is actually, I believe, Rare Disorders Day, which cervical dystonia is considered a rare disorder, according to what I know. And next week, I'm hosting my free Cervical Dystonia Reset Challenge. It's teaching the things that I have learned just to make your life more fun, easier, even while you're navigating this thing. So if you want to register, it's totally free. I think it is cervicaldystoniareset.com. Put in your name and your email, and then every day next week, you're going to get a 2-minute video and an email just sharing the tricks to work the magic, as my mom would say. And with that, we peace out.
Awesome.
Thank you, Stephanie.
Yes, thanks for having me
Of
and
course.
we'll stay
Okay.
we'll stay in touch.
Okay. Ciao.